Every time I go to a conference, I come back, I'm more depressed because they say we're aging faster in HIV, and it's like, I want to hear good news about the cure. I don't want to hear about aging. But here I am speaking about how to not age, because we're all going to end up, old, but how to live healthy while we're getting older with HIV, and how to hopefully avoid depending on other people to take care of you when we get to an age that most of us never even dreamt of. I'm 52, and I was told when I was like 25. So being in my 50s is like surreal, and for most of you too, because most of us here in San Francisco are over 50 by now. By the year 2015, over 50% of people with HIV are going to be over 50 years of age. So, but I guess we've reached that that milestone, most of us in this room. So it's actually a good thing. It's a good thing. But, there's some concerning stuff that, every time I go to a conference, I come back and say, well, there must be something we can do about this problem. So I'm going to speak. First of all, before I speak, I want to make sure that you understand that I'm not here to give medical advice. I don't have a medical degree. I'm an engineer by training, but pretty obsessive about science and research. When I found out I was positive in '86, when there was not even ACT, I knew that at least knowing about science would somehow give me some control. I'm a control freak, and that was my control. I'm still controlling about science. So it's really has helped me survive, and also I love doing these lectures because I try to digest some of this complicated information and make it more available to all of us. And the slides, I have a nonprofit called Program for Wellness Restoration, and the website is powerusa.org. And we're going to have slides. I'm going to speak a little bit about lipodystrophy, people. I went to a conference in Rome just July, and somebody actually had a presentation that said, is lipodystrophy still relevant? And I was like, what do you mean? So there are actually researchers and doctors that think lipodystrophy is not really relevant. But there's some data that shows that, we still are dealing with some issues on lipodystrophy. Bone loss is kind of freaking out everybody. It's in every conference. Every conference has more and more presentations on bone loss and what are we going to do about it. Protecting anal cancer. I've been positive forever, like most of you guys, and I've known some friends that already had died of anal cancer with HIV or have had to go through chemo or radiation, and is becoming a very concerning cancer. Exercise, I'm going to speak a little bit about exercise because it can get boring if you're not actually doing it, but some data on that. I'm not going to take my clothes off and be in shorts jumping up and down. And testosterone is my thing. I've always written about hormones. I wrote my first book on anabolic steroids and HIV wasting, and I just published one for testosterone for men. And so I may just, there's some good new things about testosterone that's actually exciting, and new products, and some questions. I want to show this slide to scare everybody. Actually, I didn't mean to scare, but these are a bunch of what we call comorbidities in HIV. Most of us don't have any, so don't freak out. Most of us don't. Most of us may have one or two. Some people are just so healthy. The older we are, of course, the more exposure that we've had to the bad drugs, the ACT, D4T, Crixiban, high doses of Norvir. Most of us were probably. How many people here have been positive for more than 20 years that you think of? Yeah, so 50, 40%. How about less than 20, more than 10? Yeah, like 20%. How about less than 10? How about just less than 5? Oh, you guys are coming. I was always assuming people that had less than 5 years of exposure and never cared to come to lectures. How about just recently, like 2 years? Oh, wow, good for you. I mean, really good. It's good actually that you're here, because the beginning of any grieving process, we tend not to want to face anything, especially when it comes to scientific information on a disease that we don't want to deal with in the first 2 years. But anyways, a bunch of us are welcome. Anyways, a bunch of us may have, there's the lipodystrophy, hump situation, the facial lipoatrophy, cholesterol issues. This is a picture of visceral fat. Some people may be dealing with diabetes. Body image alterations. This is actually a slide from one of the experts of aging and lipodystrophy in Italy. HIV-associated neurological disorder. we used to call it cognitive disorders, heart disease, liver problems, bone problems, or kidney disease. So it's a lot of high blood pressure, vitamin D deficiency, also diabetes, some cancer. So these are a bunch of stuff that research groups, every single one of these aspects is being followed by research by different HIV researchers. So it's kind of concerning that, we may have, some of us may have one or two or three of these comorbidities, but they're actually people presenting information about each one of these, most of them, in most conferences we go to. So it's, people say, well, nobody's doing anything about lipodystrophy or aging. Well, that's not true, really. There's a lot of work being done, especially, and we're concerned now with the cuts in research funding that maybe we won't have as much. But when it comes to aging and HIV, basically we have an overlap of what HIV itself causes in the body and the aging process causes, and what also medications may produce. So there's some effects about that HIV itself causes inflammation, some even bone disease is probably linked to HIV, inflammation or heart disease, cognitive declines, and aging also. So we have to age with a virus in our bodies. This is a complicated graph, so don't be too worried that you're not they're too busy. But this is just to drive you to the message. This Dr. Guaraldi in Italy is probably I respect him a lot because he's following the aging population in HIV in Italy, and he's measuring how many comorbidities, how many problems they're having, and comparing those problems to the problems that people without HIV are having. And what he's seeing is that people around 41 to 50 HIV positives have more or less the same number of problems that an HIV negative in 51 to 60 years of age. So we're having earlier symptoms, like 10 years earlier than the HIV negatives while we age. We have more comorbidities. So, and we keep hearing that in different conferences. There seems to be like an acceleration of 10 to 15 years in many of the parameters that we're seeing. But I tend to remind the younger ones, the ones that have been positive for less than 5 years and that have not been exposed to a lot of this horrible stuff that we've been exposed in the past, that this data is really older HIV positive that have been exposed to E4T, ACT, Crixivan, all the nasty stuff. So we cannot correlate, we cannot say that the younger the people that have been taking medications for less than 5 years will have the same problems. That cannot be proven, and probably we will not have as many because the new drugs are a lot friendlier when it comes to a lot of the side effects that we used to have. But the visceral fat situation is kind of losing coverage in conferences. Lipodystrophy is really not a word that is used anymore hardly in conferences. We talk about metabolic disorders, we talk about other things, but the word lipodystrophy itself, hardly, conferences used to be called lipodystrophy conference, now it's called the adverse reaction conference. So for what reason? Not because nobody wants to cover it, it's just that for visceral fat we kind of have tried different things and very few things really work all the way. And we're seeing less of an expansion of visceral fat, internal fat, than we used to, basically because we're avoiding the Crixivan and the high doses of Norvir, but it's still there. People are gaining weight. I don't know whether we have the excessive amounts of deformities that we used to have. And the visceral fat is actually internally located within the organ cavity. This is actually a CT scan of the belly button area. So it's a different fat. It's not a fat under the skin, which really a lot of us have lost anyways due to D4T and ACT and aging. And also what studies have found that visceral fat actually can increase cardiovascular risk. So it's not only like a cosmetic thing. People say, well, I have a belly and I cannot put my clothes on anymore and I'm self-conscious, but there may be a clinical issue with visceral fat. The good news is that lipodystrophy rates have been followed by this DAD study, and in a few years, from basically the early 2000s to 2003 and 6, when new drugs, well, actually more than new drugs, people stopped using D4T and ACT as much, we are already seeing a decline in the rate of body changes like that. So that's actually good. And I think if we plotted another curve comparing the newer years, we're probably going to see more of a decline just by avoiding those toxic drugs that most doctors are not prescribing, because we found that they're not as, they did the job. Most of us probably are alive because of Crixivan and because of D4T. But it's not justifiable to be prescribing toxic drugs when there are easily 26 drugs approved. So, and another complicated graph, so don't worry about reading anything. These are a bunch of studies, actually a very rare graph that has plotted the amount of fat that people gain on different combinations, different studies, different old drugs and new drugs, different durations. And most people tend to gain 10 to 15% of their baseline. Some studies actually show no gain whatsoever, actually some even loss. And the only difference about this study is that T cells at start were a lot higher, but nobody has really found out what the real reason for putting on fat, besides maybe expansion of the immune system. And when we're getting better, our T cells are going up, we have more of a cytokine storm, they call it, where a lot of these proteins that the immune system produces to talk to each other, all the cells, are made in excess, and for some reason that inflammation tends to expand the fat cells in the internal area, in the visceral. This is new. Now people are saying, well, are drugs the same? Do all drugs have the same effect on visceral fat? And actually, this is the only study that was recently published comparing Sustiva and boosted Reatas, two very commonly used drugs, and also comparing Truvada and Epsicon, which are two backbone nucleoside analogs. And they have seen some differences already. And this is actually visceral fat from week 96. And Reatas with Norvir tends to increase visceral fat more. And Norvir usually tends to do that. But Norvir-boosted protease inhibitors also tend to increase T cells more than non-nucleosides. So is this related to Norvir, the effect of Norvir, or the effect of more CD4 expansion? Nobody has really proven. Truvada versus Epsicon. Truvada is actually the blue one. It's a little bit of an increase compared to Epsicon, but it wasn't really statistical significance. So maybe a Norvir-boosted protease, which happen to also be the most effective treatments. So I'm not telling anybody to be thinking about getting off boosted protease, because they work, they do the job, they actually increase T cells pretty well. It's just that, people tend to put on a little bit more fat on them than non-nucleosides. And this is basically the same kind of measurement, but done by DEXA, which includes both subcutaneous fat and visceral fat. The same thing, Reatas, boosted Reatas more. But in here, in this case, Epsicon had a little bit more, but not in statistical significance. So, yeah, okay, so a tripla may cause all of them, obviously. You can see in the previous slide. This is actually a tripla, Sustiva with a tripla, and it causes. Everybody gains some weight, 5 to 10%, but some people may gain weight. So I tell people, if you're going to get on HIV medications, just make sure you start exercising. No, we don't have very good data on different diets, but I tell people try to cut out the sugar, work out more. Yes, we have to work a little harder at keeping in shape. That's the only the only problem. And they have researched many things when it comes to visceral fat. The exercise, there's very little amount of data because exercise cannot be put in a pill and cannot be patented. Low carb, high fiber diets, a little bit of data that shows that people that eat a lower carb, higher fiber, more fruits and vegetables tend to may have less of a visceral fat accumulation. Egrifta is a new drug approved by the FDA. I'm going to speak a little bit about Egrifta. It's an injection under the skin, which is, not as much fun, but hey, if you really want to try something, at least it's the only drug approved for this use. Metformin is a diabetes drug, some contradicting data that may or may not work. Changing HIV medications has not really proven to work. People say, well, how about if I change from a boosted protease inhibitor to tripla, for instance? Well, once you gain the visceral fat, it tends not to go away very hardly. There's one study only that shows that there may be some improvement, but we haven't really seen improvements in changing medications. Testosterone, people that have low testosterone tend to have more visceral fat. There's actually a study that was done with androgel for the belly, in HIV and actually found that people lost 1 inch, but it was mostly fat under the skin, not the visceral fat. Which, I mean, you lost some waist area, but it's not the visceral fat, which is more clinically relevant. Anabolic steroids have been explored once in a small study with oxandrine, showing that yes, it burns actually fat, visceral and subcutaneous, but it also decreases the good cholesterol, and that's concerning. So doctors don't prescribe it for that. Although it is prescribed, anabolics are prescribed for people that are losing weight involuntarily. Supplements, I get that question all the time at the body. People say, what supplements can I take to, and really nothing has been shown to work. But there's still, some people are doing some research. Weight loss, when you lose weight in general, you lose both visceral but how many people are actually going on a really strict diet? And liposuction, so, we all know exercise works for fat, but actually studies have shown that exercise both decreases subcutaneous and visceral fat. And there's only one diet study that was done in Boston that actually saw a little bit of significant difference on people that were consuming more fiber had a lower incidence of visceral fat accumulation. And non-statistical significance, but towards statistical significance, those who were exercising. But fiber showed up 1, 2, 3, 4 times. This is all fiber. So fruits, vegetables, oatmeal, whole grains, and fruits and vegetables. So, and whole grains, and everything that is brown and heavy in fiber. I tell people, take even fiber supplements if you're not taking 20 grams a day. Egrifta is that injectable that just was approved like a year ago. It's like $2,000 a month. Obviously, ADAP is not going to pick it up because ADAP is not hardly picking up HIV medications, right? So they have a good assistance program, though. We've tested it. Somehow people are getting through. People that don't have insurance. I forget the income level. Matt, you probably remember. Matt Sharp is back there. He's also in the committee with me. But so far, nobody has emailed me saying, hey, I tried to get it. I have no insurance, and I didn't get it. So that's a good thing. It's covered by most insurance companies, but Medicare Part D, which unfortunately a lot of us have, a lot of the Medicare Part D formulators are not including it yet. It's a high cost drug, and you have to inject it every day under the skin. And like for those of you that used to do Serostim, under the skin every day. You cannot stop it because once you stop it, the fat comes back. It decreases fat depending on what kind of patient you are. It can anywhere from 17 to 27% in 26 weeks. Visceral fat, the inner fat. And so far we haven't really seen horrible side effects like growth hormone, no diabetes, no high blood sugar, very few joint aches. So it seems very well tolerated. It is expensive. It's going to be an issue. But right now, so far, I've been watching very closely what's happening out there. And people, especially people that don't have insurance also probably right now have a better chance getting it than those that have, of course, Medicare Part D. What else? Yeah, and agrifta.com is the website where the doctor can actually go in and apply for because you do have to have a doctor that applies for your patient assistance program. Okay, any question here before I shift gears a little bit? Okay, we'll take questions after Dr. Romano speaks. And you know, we're finding out through all these years that we know drugs that have higher risk of increasing cholesterol and triglycerides and those. So, you know, we've learned a lot through the years. Okay, okay. When it comes to lipoatrophy, there are good things happening and bad things happening. The good thing is that a few of us have been working towards Medicare picking up a Sculptra and Radius because they weren't paying for it before. We had actually patient assistance programs from the companies. So Medicare agreed to do so last year. The bad thing is that they're paying the doctors a very low fee, and many doctors are refusing to even take patients with Medicare. And most insurance companies are still having issues paying for the products. So it's a non-ending, it's a never-ending story. I'm actually getting tired of working on this issue because it's kind of a lonely world because it doesn't seem like there's much activism. But people are trying to get access, and some people have. I would say that maybe the people with good insurance and people with money is still not, even though we have 2 products approved by the FDA. And there's, there's severities. It's like stage 1, then, more severe stage 3 and 4. And depending, of course, on what stage you have, you will need more product, And this is a pretty severe stage where some people lost not only fat but muscle. And this is mostly due by the action of steroid, D4T. One drug. ACT also causes it, but not as severely. So this is a side effect. I don't care. And this has to, I've always, as an activist, say, it is a medication-related side effect that needs to be paid by insurance and Medicare because it was caused by a drug. We're not talking about getting pretty. We're just talking about looking healthy like we would at our age. But it's still being perceived as a cosmetic solution, not as a clinical aspect of treating HIV. So, the Sculptra and Radius tend to work pretty effectively, and this is my opinion, by the way. It has not been published in like a paper on stage 1 or 2. Once you get to stage 3 and 4, it's very hard to get really good results because these are non-permanent products that have to be injected a few times before you get some kind of response, and then every year you have to go for a touch-up. And a lot of these guys that have been in this situation have wasted a lot of money and have to, at the end of 5 years, still look pretty wasted too. So, and there are actually options. Silicone is one of the options that is actually legally used in California and in the States, and Artefiel, which is another option. Very expensive, permanent solutions for severe wasting. So Sculptra and Radius, both companies have assistance programs. Sculptra is better than Radius when it comes to assistance. Radius is, you have to still pay a percentage. They're getting harder to get in because they assume that Medicare and insurance companies are paying, so they're getting very picky. As I said, it's this activism on this whole area, it's kind of dying off because a lot of us are getting busy working on other things like cure research activism, and this is moving into the back burner. 2 products approved by the FDA, Sculptra and Radius, non-permanent, FDA approved. There's an assistance program under $40,000 a year. You can get it for free, but you have to still pay the doctor to inject it. Silicone microdroplets is also legally used, even though people say silicone. It's used off-label, and PMMA, some people are flying to Mexico to get that cheaper, even though there's one here in the States where it's too expensive. And as I said, Medicare decided to do so in 2010, yet most doctors are complaining that, and we're trying. We send letters to Medicare saying, hey, the fee you're paying is not going to spread access to these drugs. This is using silicone, 14 treatments after 2 years, 24 cc's. These treatments are $900 each. So this girl paid 14 times $900 out of her own pocket to get from here to here after 2 years. And this is Radius, basically 1, 2, 3, 4, 5, 6, 7, 8 sessions to go from here to here, at an average also of $900 if you don't get reimbursement. So it's an expensive thing, and it's also, unfortunately, not everybody has access to look healthy again, but it's unfortunate. And the bone situation, it's one of those things where we're having more answers. I think I'm going to talk a little bit about vitamin D. Bone health, bone density actually goes up and then peaks during age and then goes down after we're 45 or so. But in HIV, what we're seeing is that when we're comparing positives to negatives, the incidence of bone loss is a lot bigger. I mean, it's dramatically different. We're definitely losing bone faster than just the bone loss are related to aging. Probably the only way to find out for sure if you have bone loss is doing a DEXA scan. It's basically a prescription you get from a doctor. A hospital, usually big hospitals have the machine. It's a tricky situation. It's cheap. It's only $130 if you have to pay for it, and many doctors are not writing an order for it. Why? Because we don't have guidelines that say, well, now they're trying to change the guidelines for anybody over 50 years of age, HIV positive, should get a DEXA scan every few years. But right now, unless you ask for it, you won't get it. And if you ask for it, you probably will get it, because most doctors, what's happening now is that doctors are waiting until you have a fracture to say, oh, let's do your bone density. And by that time, it's pretty advanced. So I really am a proponent. People criticize this, but I think every HIV positive person, not over 50, but over 40, 45, should get at least one of these tests, a DEXA scan, prescribed by the doctor, and just answer that question. People say, well, what am I going to do? How about if I come up very low? I said, well, at least you'll be motivated to do a few things like working out. Exercise actually improves bone density, calcium, vitamin D supplements, and there are some drugs that are also prescribed. And if you have low testosterone or thyroid, if you improve that, the hormones, it tends to get better. And there are bunches, of course, you see the ads in TV, Boniva once a month, and of course, none of them has been, except Fosamax, have been studied in HIV. But they're like once a day, subcutaneous. This is once a week. This is once a month, and I think this is once a year. It's an IV, but we don't have any data. Mostly data on women, but non-HIV. But we'll see. And vitamin D is definitely hot. It's the only vitamin that we talk about in conferences. I mean, doctors, doctors are very hot on vitamins, but vitamin D is the only vitamin in the past 3 years that has been in every conference we've gone to. And most of us have low vitamin D. White, brown, Latino, blacks, actually the darker the skin, the more chances you have low vitamin D. And you get vitamin D from the sun. Your skin actually metabolizes it through the liver and the kidneys into active metabolic products. One of them works on the immune system. Actually, is very important for the immune system, for the prostate gland health. And another metabolite coming from the kidney works on muscle and bone health, and also regulation of bone pressure and blood pressure and insulin production. So vitamin D actually is involved not only on bone health, but also immune function and metabolic issues. So what we're finding out is maybe there's some evidence, we're not 100% sure, that some HIV drugs and non-nucleosides in the liver, or even tenofovir, Viriad, in the kidney, are interfering with the conversion of vitamin D into these two guys that actually are doing the job of vitamin D. So we have, I think, and it's another thing that people may criticize me, everybody with HIV should take vitamin D. And I'm going to explain why. Everybody. It's cheap. It's not going to kill you if you overdose. It actually may help you, even though we don't have evidence. We don't have placebo-controlled, double-blinded, long-term studies. It's something that is not going to kill you, and you're not going to lose too much money. It's very cheap. And the only way to find out is to do a blood test. Although, as I said, I have doctors that say, I don't do blood tests of vitamin D. Why? Everybody's low. Why spend $40 on a test that basically is not really, I just assume everybody is efficient, which, I think if you're in an ADEP situation, definitely why test. But yeah, these are the different levels that your doctor will go for. But as I said, vitamin D is definitely showing up everywhere. And the most interesting thing that it got published recently, is that one of the drugs, tenofovir, Viriad, which is part of Truvada, which most of us are taking, it's very rare to see somebody not taking Truvada or Viriad, unless you're taking Epsicon or Cygen or something. But most of us are taking that drug, and Viriad tends to do something kind of interesting. It's a very good drug. It definitely has worked wonders for us. It does not cause lipoatrophy, facial lipoatrophy. It does not increase cholesterol. It does not increase triglycerides. It's a beautiful drug in every aspect. It's a once a day, except that it may accelerate bone loss, and that's concerning. And what we have found, the thyroid gland has another little glands attached to it called the parathyroid glands that produce another hormone that keep calcium balance in the blood. Every time there's low calcium in the blood, these little glands emit this PTH hormone that makes bones degrade calcium to give calcium to the blood. Well, Viriad tends to affect this hormone for some reason. In so much so that it tends to increase this hormone. We don't know why, but it increases this hormone, so our bones are releasing more calcium into the bloodstream, and that's one of the potential reasons why we may be losing bone, besides vitamin D deficiency too. And the study actually looked at that. What happened to when we give vitamin D to people taking Viriad? It's actually young people that were given vitamin D. What happened to that hormone? Does it go down? And in fact, it does. For people that have actually low vitamin D blood levels, that hormone actually improved, go down. So vitamin D not only is something we need to be taking, but it's a vitamin that will reverse, even prevent some of this effect of Viriat on the PTH hormone that is very important for bone health. So, I'm a crazy activist. People criticize me for things I say, but I think, every bottle of Viriat should be attached to a bottle of vitamin D when they sell it. Like we used to have a drug called Adefovir that was attached to a bottle of carnitine because it would bring carnitine down. And that's my opinion. But hey, vitamin D is cheap. You can buy it in the store for nothing, hardly. And do it because there's enough evidence that in a few years we're going to prove that it actually has done something very important. I'm going to switch to this, and maybe I'm just not going to speak about it too much because I think you guys have been really hit very hard with the anal cancer message from the experts locally, right? Should I just skip? It's only 2 slides on anal cancer. Yeah? Talk about it? Okay, well, real quick, because here, as I say, it's the mecca of research, and I don't know whether or not you guys have had lectures like that. But, HPV infection. HPVs, somebody asked a question about HPV to Timothy, see if he was free of HPV. And I don't know whether they have checked you for that, but you probably have the HPV of your donor. That's what it is. Because I tell people if you had sex more than once in your life, even once, you probably have HPV because there are lots of types of HPV, different genotypes. Some don't cause cancer, some do. Some cause anal warts or warts in your fingers. And we're getting warts when we're kids, most of us, right? In our fingers, some of us. So it's in our bodies. Most of us have it. Some of us have the real bad stuff, especially the ones. Few of us have had too much sex in our lives. I'm not naming any names, including myself. But the more sexual exposure you've had, the more chances you probably have a lot of the different types of HPVs. And some people clear it normally. They get infected, and their immune system basically clears it. But most of us, and some of us they clear it. If you have a good immune system, some people get reinfected. They clear it, but they get reinfected. And some of us, mainly most of us in HIV, have basically remains active in our bodies. And we have a persistent infection. There's every HPV does not cause cancer. There are only 4 types, 16, 18, 45, and 56. The issue is that not a single doctor is doing the HPV test, the genotype test. I'm actually working on that right now because I want to get it done. It was approved. 2 companies have a test where you get a blood test and they can see what kind of HPVs you have, but it's only approved for women. It's not approved for men, and definitely not approved for anal cancer, even though we know HPV has a role there. So actually, with Jeff Taylor, we're writing letters to Roche and Abbott, say, hey, we're men, but we want access because it costs $280 if you have to pay for it yourself. So, but it will be a good way to find out, hey, should I be extra concerned? And the only way to really find out, people say, well, how do I know if I have a problem? We say, well, the longer the exposure to HIV, the longer you've lived with HIV, chances are, the more chances, and we've seen some incidence data that, that we may have more problems. A rectal exam, if it's that evident, if you already have issues, more than words, but how many doctors take a finger in your butt, even for prostate? Very few. I'm finding out more and more that this yearly test is not done for men and women. I'm not talking about men, I'm talking men and women, because it doesn't discriminate. And a pap smear, there's some evidence that just scraping the anal area with a pap smear and sending it to a lab to grow for growth to see if there's any irregular cells may be an indicator if you have a problem here that will pick something up. It's not 100% effective, but it's easy and cheap, and for those that have no insurance, definitely an option. But the most effective way to see what's in there is to use an anoscopy tool like this. Not a fun test to get done. By the way, if you've lived with HIV for over 20 years and you haven't gotten your butt checked, you need to get it checked. And that's another thing. And people say, well, why are you so absolute about what you say? So because, it will not hurt. If you don't have it, well, good news. But if you have anything, it's always easier to prevent it than to end up with chemo and radiation or a colonoscopy bag. What happens is this is what we call a high-resolution anoscopy. They stick this thing up your butt while you're bending over. It's kind of not really fun, but hey, we've gotten worse things stuck up our butts. But and they, of course, open up your butt. They spray. They look inside with a light. They spray some vinegar, some acetic acid, and they shine infrared light to see what mucosa actually shines differently. The cancer mucosa tends to shine very different than healthy tissue. So they can actually see, and then some doctors go with infrared coagulation or to cauterize and cut and send it to biopsy. I've gotten that procedure done 3 times. But I catch it on time. So I'd rather do that than, and it's not a test that you are looking forward to doing. So people tend to put it off, and people say, well, I haven't had any problems. How do you know if you have a problem? So sometimes you don't. Sometimes you have some bleeding, thinking it's a hemorrhoid or rough sex or something. Sometimes it's just this inflammation that you feel that could be caused by many things. So there's no way to find out unless you go for the actual anoscopy. And the UCSF website has become a worldwide leader in this work. So once again, being in San Francisco, you have basically no excuse not to at least access the best in the world here. I have a book that I published. I have 4 that I'm going to give away to people that ask good questions at the end. So stay awake. Those, as we age, men and women have decrease in testosterone blood levels, and there are bunches of symptoms that go along with that. The first one is complete not really being interested in sex or even masturbate or no thoughts of sexual activity at all. I tell people when you don't even have dreams of sex. And loss of lean body mass, bone loss, low sperm count, depression, lack of focus. And testosterone has an effect on basically a lot of different organs and tissue in the body. And this is a male body, but women also have testosterone mostly for the same reasons that men, produced by the testicles, for bone health, for the brain health, sexual health, and lean body mass. And it's actually the pituitary gland is the one that controls the testicles to produce testosterone. As we age, of course, testosterone goes down. There are many theories about that. Testosterone, when it's produced by the testicles, is not just testosterone. It's free testosterone. It's a tiny little portion. And there's a sex hormone binding globulin testosterone attached to testosterone that really does not do any work whatsoever. What happens with HIV and aging is that the sex hormone binding globulin increases. So there's more binding proteins to the free testosterone. This is actually the guy that does the work. The albumin bound actually is like a storage. It gives in testosterone when you need some. So it goes down free and total. There are 2 different tests, and that sex hormone binding globulin goes up with aging, HIV. Some medications increase that too. The only way to find out is not only having the symptoms, but getting your blood levels tested by your doctor. And I tell people, if you're going to start testosterone, you need to know this. And very rarely I find somebody that actually knows. They're doing androgel testing or injections, and that have been told about this from the doctors. This is actually a cascade that we have in our bodies that control hormones. Every hormone is connected to the effect of another hormone. Everything is a cascade. This is the HPTA hormonal axis. H is the hypothalamus, P is pituitary gland, and T is testicles. So basically, the H sends a signal to the pituitary sends a double signal to the testicles to produce testosterone and sperm production. When you have too much testosterone or enough testosterone, there's a feedback loop that tells these 2 guys, hey, slow down, we have enough. Don't send us any more signals. What happens is when you inject testosterone or do the gel, this testosterone, this axis is completely disrupted. You don't have any more production from your own testicles anymore. You're basically getting it from the product. And this whole axis gets shut down completely, except sometimes there's a little bit of it, but this definitely gets shut down. So if you're going to do testosterone, remember that your axis is going to be shut down, and that's okay because sometimes we need testosterone, and what the heck, we have to use it. But if you ever get off testosterone suddenly, and many people do, this axis is going to stay shut down for a while. For some people, maybe a few weeks. So for some others, maybe a few months. and to return testosterone to production. Most of us did not have good testosterone production to start with. That's why we started testosterone. So we'll never return to normal. But it's something nobody tells patients. Oh, you know, they all want testosterone. Everybody wants testosterone, but they forget to tell them, hey, if you're going to get on it, it's a big commitment, because once you get off of it, you're going to suffer a lot of the symptoms for a while before you even have some testosterone back in your body. Yes? Yeah, no, and HIV, no, I'm talking, this is normal. This is for everybody, HIV positives and negatives. It's everybody, for everybody. Oh, good question. We don't know. You don't know. There's like some studies say 30% of us have low testosterone. Actually, I'm going to show some data. That's actually a good, and don't want to worry about, this is new data from Rome. This Dr. Guraldi, again, the Italian guy there, he keeps presenting stuff that I'm very interested in, but nobody talks about the data that he presents for some reason. But he's kind of a very, very smart doctor in Italy. He measured testosterone levels in HIV positive men. And just to see what kind of, whether or not they had low testosterone because these guys were not working, or the testicles were not working. There are different reasons why your testosterone is low. It could be primary, secondary. I'm not going to bore you with details. It's more in my book. So we basically found that a lot of us have, the ones that have, these are normal testosterone. There's a primary hypogonadism, secondary hypogonadism. So basically, a lot more of us are having secondary hypogonadism. What does that mean? That our pituitary gland is not producing a lot of these two guys for some reason, and we don't know why. We don't know if it's the virus affecting the pituitary gland, but this signal that is needed for the testicles to produce testosterone is not getting there. We're not having as much. And we have no idea why that's the case. And in other cases, we're producing a lot of these two guys to jumpstart the testicles, because it seems like the testicles are getting fatigued. We don't know why either. Could it be inflammation, activation of the immune system? We don't know. He also has compared the incidence of the low testosterone in positives and negatives, and we have seen is that we have the same incidence. A 45-year-old HIV positive man has more or less the same incidence as a 58-year-old HIV negative man. So once again, that 10-year difference shows up in every single study. We have a 10-year acceleration or early show up of symptoms. You may finish this. And for those that have the low testosterone, they also have more visceral fat. Okay, I'm going to go real fast. I don't have much time. Benefits when you do testosterone, when you have low testosterone. Testosterone should not be really taken by anybody that doesn't really need it. Why screw up with your hormonal axis? And testosterone converts into DHT. Estradiol is a female hormone. It can cause side effects like water retention and increase in breast size. The gynecomastia in some men that start testosterone. And as this is an injection of testosterone. A lot of people do injections. I've been on testosterone for 20 years. And it really has saved my life, because I was wasting, and not only testosterone, I also did nandrolone and oxandrolone. You know, I did all the anabolic stuff too. But testosterone can do a lot of muscle building for those that are wasting. But what happens is our testosterone goes up when we inject, and then goes down, goes up, it goes down. But so does estradiol and DHT. So there's a cycle that you go through if you inject. And doctors are prescribing a lot more gels, because it keeps your blood levels more constant. There's a new product called, I forgot what the name is now. I don't even use it. It's actually an underarm spray. And now they're coming up with Nebido, which is an injection that lasts 3 months. It's actually a good product that's being approved everywhere else except the United States. And Livigel, which is a gel for women. The first product approved is going to be approved for women. Okay, I'm going to skip. And this is important. This is the last thing I'm going to talk about testosterone. If you do testosterone, you need to know your hematocrit. Hematocrit is a proportion of blood cells, red blood cells in your blood. And testosterone actually increases red blood cell production, which is a good thing if you have low red blood cells, but it's not a good thing if you have normal red blood cells, because your blood gets thicker and you can have a heart attack. And if it can go up, if your hematocrit goes up above 52, and many doctors don't know this too, that's why I wrote the book. I have no idea why. I see patients, I ask them, I actually have people show me their blood work, they have 62 in their hematocrit. They're walking ticking bomb. And doctors don't know that you need to send those patients to have their blood drained to bring the hematocrit down, or have them stop testosterone. And most patients don't want to stop testosterone. So that's important. If you're going to do testosterone, definitely know that you can have a problem with hematocrit. Also, some people complain about shrinkage of the testicles because when you shut down your hormonal axis, testicles are basically not producing your own testosterone at all. You're basically getting testosterone from outside sources. And there's actually another hormone that is getting more popular. It's very cheap. It's called HCG, not. It's chorionic gonadotropin that actually jumpstarts your testicles to get normal size, and now we're using it a lot in combination with testosterone. I write about that protocol in the book. It's becoming more popular to combine these two, testosterone and the HCG, to keep your testicles kind of in a healthy way. Your prostate, if you have prostatic cancer, you cannot do testosterone. You can make it worse, but testosterone has not been shown to cause prostatic cancer. So it's kind of a weird thing. People say, oh, how about my prostate? So you do have to get your prostate checked frequently, PSA test. There's more on this website. You can find the slides on there's a handout. Now I'm going to speak about exercise. I'm going to just let you guys read it at home. There are websites that are really good websites with videos. And this is my contact information. You can email me at nurseonvergel.com. I write for thebody.com. TPAN is great too. And you can also subscribe to my internet discussion chat room. We have over 3,500 people.